So thank you very much, Dr. Akhtar Ali Bandesha and the organizing team for holding a beautiful conference and giving me opportunity to talk on this subject, which is heart failure, diagnosis of heart failure. So my talk would be on 2022 guidelines, which were published in circulation in 2022. So before these guidelines could be published, our understanding of the heart failure was any condition in which heart is unable to meet the metabolic demands of the body. That is heart failure. But after this, the guidelines changed, and the current definition of heart failure is that it is a complex clinical syndrome. So it is not a disease, it is a syndrome. Because it is affecting so many organs, it is affecting the central nervous system, it is affecting the peripheral nervous system, it affects the kidneys, it affects the GIT, it affects the peripheral vasculature. So it is a syndrome, it is not a disease. With symptoms which the patients explain and signs which the doctors see that result from any structural or functional impairment of ventricular filling or ejection. So it can be a systolic dysfunction of the heart, or it can be a diastolic dysfunction of the heart. So heart failure is a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of the blood. So when the writing committee was writing these guidelines, they found that there were few patients who were vulnerable to develop heart failure. Didn't have heart failure actually, but they had some disease process going on, which made them vulnerable to develop heart failure. So the writing committee recognized that asymptomatic stages with structural heart disease or cardiomyopathies are not covered under these definitions. Such asymptomatic stages are considered heart failure stage A or pre-heart failure stage B. And these are the four, can I go back a slide, please? Yeah. So they came up with the idea that heart failure is basically these four stages of heart failure. So stage A, B, C, and D. Stage A is that condition in which the patients, they have some predisposing disease factors, but they do not have any structural abnormality, and neither they have any symptom of the heart failure. So disease process is there. For example, they can have diabetes, which can lead to heart failure. They can have hypertension, which can lead to heart failure. They can have a history of dyslipidemias or history of chronic smoking or a family history of familial cardiomyopathies, but they do not have any structural abnormality and they do not have any symptom of the heart failure. So this is stage A. In stage B, these patients have any structural heart disease, but they do not have any symptom. The structural heart disease could be like in diabetes mellitus, they can have non-occlusive atherosclerotic disease, or in heart hypertension, they can have concentric left ventricular hypertrophy, but the patients do not have symptoms. So structural heart disease is present. For example, rheumatic heart disease, they have mitral stenosis, which is not critical. They can have aortic stenosis, which is not critical. They do have structural heart disease, but there is no symptom of heart failure. So this is stage B. In stage C, structural heart disease bhi aa gayi or symptoms bhi aa gaye. So in stage C, they have got structural heart disease. For example, diabetic patients who have had myocardial infarction. So they have got structural heart disease and they have symptoms of heart failure. But these symptoms are well controlled with medications. आपने थोड़ी बहुत medications की heart failure की and heart failure के patients stable हो गए. So in stage A, there is no structural abnormality and no symptom, but the patients are at verge of developing heart failure. In stage B, there is structural abnormality, but there is no symptom. And in stage C, there is structural abnormality and the patient are symptomatic. And stage D is advanced heart failure. So if you can see that these stages merge with each other, if you do not diagnose stage A in time, it will go into develop stage B, and similarly stage B, if it is not diagnosed properly at time, the patients would slip into stage C and then stage C. So stage A is like having diabetes or hypertension or hypercholesterolemia. Stage B is heart disease, any heart disease, but the patients are asymptomatic. Stage C is symptomatic with heart disease, and stage D is marked symptoms at rest despite maximum therapy. Then this is another classification system in which there is heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. If the LVEF is less than 40, these patients have heart failure with reduced ejection fraction. And if the ejection fraction is more than 50, these patients have got diastolic dysfunction. That means that the systole is okay, but the diastole is impaired. So there is impaired filling of the heart failure symptoms. So the diagnosis, which is the purpose of this talk, my specific talk, is that the diagnosis of heart failure starts when the patient enters into your clinic. So diagnosis of the heart failure starts at that time. So you take a detailed history, you listen to your patient, you take a clinical examination, you auscultate the patient, you have a clinical detailed evaluation, and then you go on to the initial investigations, and then you go on to some fancy further investigations. So this algorithm is very important. So if the patient is suspected heart failure, for example, if the patient is having diabetes only, so you will classify that patient into class A heart failure. And then you would listen to the patient regarding his history, any history of chest pain or shortness of breath or orthopnea or PND or ankle edema or things like that, which point towards heart failure. And then functional limitation, tiredness, and remember, tiredness and fatigue, they are very important symptoms of heart failure. So we must keep that in mind. Functional limitation, डॉक्टर साहब पहले तो मैं मस्जिद में चला जाता था लेकिन अब नहीं जा पाता हूँ, या अपने दोस्तों को मिल लेता था लेकिन अब नहीं मिल पाता हूँ. And prior cardiac disease of any nature, like stenting or valve replacement or something like that. Then you come on to the physical examination, in which you auscultate the heart, you see for any murmurs, or you auscultate the lungs and feel for the heart rails or some rails or any signs of moist lungs. Then the initial investigations, they include lab work, chest radiograph and the ECG. So the lab works, they include blood complete. You want to see that the patient is not having any anemia, because anemia can precipitate heart failure. Patients with polycythemia, they can have heart failure. Electrolytes are very important because you are going to give them diuretics with which sodium can come down and potassium can go up. And then renal functions are very important. Urinalysis, glucose, HbA1c, iron studies. You know, now we have got a substantial evidence that replacement of iron in those patients who are iron deficient and who are having heart failure, they improve the symptom. So thyroid function, they are all very important. Then chest radiograph and ECG. Only then you go on to the further investigations like pro-BNP or assessment of ventricular function with the help of echocardiogram, and additional testing like cardiac cath or cardiac MRI or MEB scan or MUGA scan or things like that. So coming back to these guidelines, it is extremely important to have a detailed clinical evaluation, including history and physical examination. So this is class 1 recommendation. Then recommendation for initial lab and electrocardiographic test. This is again class 1 indication that you should have these investigations at least, which include blood complete, urinalysis, serum electrolytes, urea, nitrogen, creatinine, glucose, lipids, liver function test, iron studies, and thyroid stimulating hormones. And ECG, this is class 1 recommendation. So after getting these tests, you go on to further investigations, which include a chest X-ray, in which you can see the pulmonary congestion or increased size of the heart. Then you go for the transthoracic echocardiogram, angiogram, cardiac MRI, or CT scanning of the heart. These are all class 1 recommendations. And then you go on to develop for the BNP and pro-BNP levels. So this BNP and pro-BNP, these enzymes are very helpful. These enzymes are friendly enzymes for patients with heart failure. These are not bad enzymes because these are being secreted from the heart when the heart is stretched. So these enzymes, they lead to natriuresis and diuresis. So as long as they are in the circulation, the patient is having natriuresis and the patient is having diuresis. This enzyme is inhibited or broken down by neprilysin. And this is the basic role of ARNI, which is revolutionary treatment for the heart failure. You'll be having talks on this. So pro-BNP and N-terminal pro-BNP. So this is BNP, and this broken segment of this is BNP, and this is pro-BNP, N-terminal pro-BNP. So you can have lab assays to detect these in heart failure patients. And then 2A recommendation is that if the patient is having some infiltrative disorder in which you are not sure about the diagnosis, 2A indication is that you can have their endomyocardial biopsy or invasive hemodynamic monitoring. And recommendation for genetic evaluation, if there is a young patient with heart failure and there is decreased ejection fraction and there is no other history कि उसने कोई हकीमी दवाइयाँ नहीं खाई हुई, कोई पुड़ियाँ नहीं खाई हुई या कोई ऐसी चीज़ नहीं है, तो उनके फर्स्ट डिग्री relatives की screening जो है, that is class 1 indication. So this is my last slide. So this is basically a summary of all the investigations. So suspected heart failure, do have a clinical examination, detailed history, detailed clinical examination, then initial test including chest X-ray, ECG, BNP, pro-BNP, and lab works. After that, you go on to have an echocardiogram, and later on, you can have CMR or radionuclide imaging or catheterization of the heart. So thank you very much.